I now invite Dr. Sujatha Mohan of Rajan Eye Care to talk about the principles and how to do an anterior vitrectomy.
Can you switch over to this AV people? Hello? Is anybody there? Can you switch? Okay, thank you. So good morning everybody. At the outset I'd like to thank Dr. Haripriya for calling me for this course once again. And my topic is going to be on vitrectomy principles for the anterior segment surgeon. So the key components in the management of vitreous loss in PCR are early and quick recognition, which she already showed, avoidance of hypotony, maintenance of a closed anterior chamber, prevention of PCR extension, prevention of nucleus drop, prevention of vitreous traction, and ultimately IOL implantation. So how do you recognize an early PCR? There is a sudden deepening of the anterior chamber, there is a tilt of the IOL, and what you can see is a very subtle pupillary snap sign. So in which case, don't panic, avoid withdrawal of the phacoprobe, maintain the foot better in irrigation position, insert a dispersive OVD through the side port, and withdraw the phacoprobe once the AC is formed. So this is a classic case of what not to do, because this was done by a trainee. You can see this was done in 2007. And already there is a PCR and he has not noticed it. There is a nucleus drop as well, and he is continuing to go ahead with his infusion aspiration, and you can suddenly now he'll realize what's going on, and then he's going to pull out. You see, once he pulls out, there is a very large widening of the PCR. So this is exactly what you should not do. So do not shallow the anterior chamber, whereas the same PCR is being handled by a senior surgeon. The surgeon has noticed a small PCR, so now he has reduced all the parameters, lowered the bottle height, reduced his phacos. He is going in for a slow motion phaco and removing the very, very small bits very slowly without causing an extension of the PCR. And most importantly, you notice after he has finished removing the nucleus bits, he is going to come out and inject the OVD to cover close the defect before pulling out his phacoprobe. So that is the key. So don't immediately pull out your irrigation. Make sure anterior chamber is deep and insert an OVD. So this is a diagrammatic representation showing how you can insert an OVD even in the presence of nucleus bits. Try to go and plug the hole so that the nucleus bit floats up, and Dr. Minu showed such lovely examples of how you can convert even after a PCR. So this is again, you can do a controlled phacoemulsification with the small nuclear fragments. If you are not comfortable with it, you can use viscoelastic to remove the small bits, because removing nuclear fragments which are very small can be very difficult, and so and sometimes they can fall in. So the most important thing is to plug the opening. So the next thing you do is, once you have found out there is vitreous, you convert into bimanual anterior vitrectomy. Don't go ahead with your coaxial. So AC maintainer with the flow directed towards the angle, new side port for sleeveless vitrectomy cutters, lower the bottle height, and most importantly use the highest cut rate the machine offers. So suction has to be low, your vacuum has to be low, but the cutting rate has to be high. And use triamcinolone to stain the vitreous. The vitrector is placed just below the tear towards the optic nerve. The vitreous cutter is maintained centrally and not moved peripherally. So you cut and move forward, you cut and move forward. Don't drag the vitreous. If you drag the vitreous, then you are likely to cause giant retinal tears. So this is a classic example of what you can do. In spite of the fact, you see there is a PCR and we have already converted to bimanual method, and there is an infusion and aspiration going on. So we have switched, so you can do that. You can every time you come out, you inject viscoelastic and then you come out. See, in spite of using bimanual, you can see that the PCR is extending. So that this step, at this point of time, there is a vitreous loss as well. So you will have to start doing a vitrectomy. So it has to be a bimanual vitrectomy, and what you can do is to prevent further worsening of the opening. You inject some viscoelastic and do vitrectomy cutting. You can use the same vitrectomy cutter to aspirate also. Once you have removed all the vitreous, you can do that. Don't aspirate in the presence of vitreous. So once you have done that, now the next nerves you have completely cleared, you can inject an IOL and do a pupil capture, optic capture, just like what Dr. Menu showed. So that is very important. This is again another case where there is a very small PCR which has been noticed by the surgeon. And so immediately, so what's happening? He has kept his phaco port inside, and you can see the very small PCR here. and he has converted into bimanual. Now for the aspiration, he is doing aspirating the cortex to become bimanual aspiration is going on, and injecting the viscoelastic. You can, it's a very small PCR, so you can even go ahead and put a single piece IOL in the bag. So the most, see at the end of the case, you can see that the PCR is not extended. That is the most important thing. So vitreous management is very important. Triamcinolone should be used to stain the vitreous. Avoid using cellulose sponge vitrectomy. Don't sweep the wound with a spatula. Anterior vitreous traction can cause a pull on the vitreous base and anterior retina, which can lead to GRT. And vitreous cutters should be used to cut the vitreous even in the wound. So this is again a case of PCR where the vitreous has been stained and bimanual vitrectomy is being used, and you can see the vitreous cutter is used to remove all the vitreous remnants which are being stained, and you can see some amount of vitreous remnants in the wound as well, which is going to be removed with a vitrectomy cutter. And see, as you're removing the cortex, sometimes the vitreous will present, in which case you have to stop, convert again into vitrectomy, and the vitreous from the wound you should be cut, should not be pulled. You can see that I am cutting it as I am pulling it forward. So that is the most important thing, a lesson to learn in this. So how to avoid posterior vitreous traction? Fast cutting rate, low suction, low flow rates, keep the cutter stationary, and advance slowly forwards as the vitreous is cut. Do not pull out when the vacuum is on, and the cutter tip should always be visible. So you have to understand that the vitreous acts like a slinky. So as soon as the vitreous loss, it continues to prolapse. If it's a very small prolapse, you can just continue with your anti-vitrectomy. But if you have a very large prolapse, you have to do a pars plana vitrectomy. And this, I'll just show you a case of how, this is a diagrammatic representation showing how a pars plana vitrectomy removes the vitreous much better than doing an anterior vitrectomy. So in this case, the patient had an IOL already implanted, but you can see that this continuous vitreous prolapse coming out. So making inserting through the pars plana, introducing a trocar, and through the trocar and cannula we are doing a bimanual vitrectomy and removing the vitreous. The advantage with this method is the vitreous gets cut off from the way from where it gets prolapsed. Whereas if you do an anterior vitrectomy at this point, it continues to prolapse. You may cut, but more will come, more will come. So when you go from the bottom and you cut off the vitreous, then it falls backward and you are able to completely clear the vitreous. So this is the last case I'm going to show. This is a very small, very normal case. You can see a slightly smaller pupil, but very soft cataract. I didn't expect much to go wrong with this case. And I mean, it's always important, whatever stage in your life you're in, you should always be aware that each case is different and you have to be aware of what you're doing. So this is, it's a very grade 2 cataract. And you can see now I've just made one division. And now see how far I'm going in. See, this is a mistake I've made. This is a place where I've gone too deep, and you can see already see the PCR there. So I also noticed the PCR. So what I did, so I decided to just bring out all the nuclear, because it was a small cataract, we were able to bring it out and keep it out. And then I'm using a bimanual anterior bimanual IA for removing the small bits. Because it's a soft cataract, we can go ahead and do that. And once you have done that and removed all the vitreous, all the cortical, all the nucleus matter, now what I'm going to do is I'm also doing an IA to remove as much of the cortex as possible. You can see the PCR has extended quite significantly. So now I'm going to put a lens just like what Dr. Minu showed, so and use it as a scaffold to remove the rest of the pieces. The most important thing here is to prevent the pieces from falling. You have already removed all the cortex and the bag is clean now. So I'm injecting a multi-piece IOL. I put it on top of the iris. You can put it on top of the iris, or alternatively, like what I'm doing now is I'm inserting it into the sulcus. Just make sure that you don't put it, you put it on top of the sulcus and not inside the eye. So once you have done that, then you can go ahead and do the phaco and remove all the components of the residual nucleus bits. So to summarize, always go bimanual. Once you have PCR and you know there's going to be vitreous loss, go bimanual. Stain the vitreous is very important because that becomes the order of the day today. Use a higher cut rate, very important to use a high cut rate during vitrectomy and low vacuum. And in cases where there is continuous vitreous prolapse, do a pars plana vitrectomy. Thank you.